So we shall now go on to our next surgeon, Dr. REENA SETHI, who's again a co-founder and ophthalmic director, eye surgeon from Arunodaya Eye Hospital. And she's a cataract, refractive, and also pediatric ophthalmologist, besides all her other extracurricular amazing talents. So on to you, Dr. REENA.
Thank you so much. Can the staff people help me in the video? I think you have the video with you, if that would be possible.
Yes, ma'am, I'm playing.
Yes.
Thank you. If you can reduce the volume for me, please. Yeah. So actually what happens is now we are really into refractive cataract surgery. A lot of cases are, where, this is a case of a high myopia in which I wanted to put in a 3-piece lens because that was what was available for the PAR. And what I saw was that, here, because of not loading it properly and not checking that the trailing haptic was stuck in the cartridge, what I had was that I lost the trailing haptic. This is a situation where I'll have to take this lens out because no way this lens is going to be the right one for the patient. And when I take it out again, what happens is that this is not a right way to take out the lens, because when you pull it out with just the haptic, what's going to happen is that you have the haptic in the hand, and then that's what is going to happen, and you need to change these lenses. The other situation where you need to really change is like this high myope, where there was an IOL surprise of about -3 diopters, and it was already 3 weeks post-op. So we needed to change this lens. This lens had to be taken out. And in these cases, the most important thing is that these cases could become difficult if we don't go through the, proper steps. The most important part is that we need to have a good viscoelastic to protect the endothelium, a good viscoelastic so that the posterior capsule is protected, and the separation of the anterior capsule from the IOL is very important. So very gradually we need to do it. A two-hand approach is always good, where you lift it and you put some more viscoelastic under the capsule and release it. The haptics have to be released out of the bag very gently. We should not be in a hurry at all, because this will take time, and so be very, very gentle and very, very slow in this maneuver, because you anyway can at any moment just pull the bag out. I like to do the scaffold technique because I think this really protects the capsule very well. And once my intended lens, which needs to be the right choice IOL, which has been calculated and put inside the bag, is in the bag, then it becomes easy that I'm protected my posterior capsule. Here again, we need to put a good viscoelastic, good OVD, and with these micro scissors, we need to just cut the lens. We needn't really enlarge our main port. Maybe we just need to probably make it a 2.75 or 2.4, depending on how small the pieces are. And with sufficient amount of viscoelastic, we need to just deliver these pieces after they cut into smaller bits, and the gentle removal of the viscoelastic at the end of the case. So this is another case in which there is a change in the preference of IOL. This is a mono vision lens which was put in the patient's eye, and this lens was very nicely, again, it was there because it was again with viscoelastic. We need to just lift the lens out and release it from the capsule all around. This maneuver has to be very gentle, because once we do this, lift it up, create a space once the haptics are in the anterior chamber, and put in the intended lens. Again, the scaffold technique. This technique is always the choice of technique which I would propagate, because it's protecting my posterior capsule here. And put the lens in place and leave it there, dial it into the bag, see that all the haptic and everything is inside the bag, protecting the posterior capsule. Once that is done, put in more viscoelastic, and you need to just cut this lens again into little bits, and you need to take this out. What's important here is that you shouldn't be doing these procedures if you don't know, if you feel that the patient has got a very low endothelial count, or if the anterior chamber is very shallow. And these are the places where you would sort of not probably go in with your micro scissors and cut the lens, because could be tricky, could be challenging. So this is my option for a refractive lens exchange for these patients.
Thank you, Dr. REENA. You really nicely showed different ways of dealing with it. But just that you're doing a surgery in a high myope. Sometimes, the first situation where, second situation where within 2 weeks you have intervened, and it's very easier to remove the IUL, and you have put a scaffold which has sort of protected the posterior capsule. And not just that, protecting the posterior capsule alone, but in high myopes, AC fluctuations itself can cause a PVD or a retinal break, and it's a different scenario altogether. So if small surprises are there, and if you're a refractive surgeon, I think it makes sense to do a bioptics and correct it on the cornea rather than jumping to do an IOL exchange. And the other situation where much later on they change the lens, I just want the experts' thought. Would you think of placing a piggyback IOL in such cases instead of cutting the primary lens? Dr. Sanjay Chaudhary?
Yeah. So there are two points which you have highlighted, Dr. Chitra.
Yeah.
One is that once the IOL is in the bag,
Yeah.
at 2 weeks, it is still safe to take it out.
Yeah.
Once it goes beyond 3 weeks, then a kind of fibrosis sets in. And the fibrosis, like Dr. REENA showed, is usually along the haptics first.
Yeah.
And then when you pull out the haptics, you're not kind of rotating it, you're pulling it out as if you're pulling it out of like a tube. And along with that, a band of fibrosis also comes into an anterior chamber, which you showed in your last video. Yeah. So the fibrosis and the shrink wrap effect of the capsular bag is to be considered. That is why what we do is, in these cases which are beyond 2 weeks, first, like you did, was you separate the anterior capsule from the IOL. And then, not a hydrodissection, but a viscodissection. You place it under the anterior capsule, let the whole visco wave go under the IOL to the opposite side, press to separate, and again a visco wave on the other side. So your whole posterior capsule is separated from the IOL. And then even you can't again still dial the IOL, you can kind of just pull out the haptics in its track. That is one. But yes, these days we have very good piggyback IOLs. I would certainly try to avoid this situation because you can always land up in a problem. And why not just place in a piggyback IOL? In any case, I have a lot of space there because the IOL is just 1/3 the thickness of the original lens.
Yes.
So piggyback will do very well there.
Yeah.
It's a much easier procedure.
Yes, Dr. Basin or yes, Dr. Arun, you could tell before we go.
Yeah.
To the speaker.
Yeah. Just in addition to what Dr. Sanjay Chaudhary has said, in case of closed loop IOL, like the second case of Dr. REENA SETHI, and if it's a long-standing case and it was a hydrophilic lens, and the piggyback IOL is not a choice once there is a opacification of IOL.
Yes.
Because we have removed many opacified IOL. In that case, you have to remove it. So if it is a long term, because usually it's a long term, opacification happens after quite a bit of time, sometimes 2 years, 3 years, 4 years. And if it is a closed loop lens, even after producing a viscoelastic wave, you are not able to sort of separate the posterior capsule, especially once it's a closed loop, you don't have to rotate the IOL. If gently you are not able to nudge it out, you can cut the haptic at the haptic optic junction and leave it there. Otherwise, we will disinsert the bag. And just cutting the haptic and putting a new IOL in the bag will serve the purpose.
Yes, and Dr. Purima
in the
Anaga?
Yeah,
So,
or a 3-piece in the sulcus.
3-piece in the sulcus as a piggyback.
Yes.
No, he said when you're leaving behind the haptics and you're removing only the optic.
Optic.
If the capsule, anterior posterior capsule also has fibrosed,
yes,
in the rest of the places, and if you're not able to actually put it in the bag, then you can put a 3-piece in the sulcus.
Yeah, that can be done. That is a good idea. Yeah. But I fully agree, and it was beautiful surgeries what Dr. Sethi has shown, and beautifully managed. But the thing is that after 2 weeks, after 1 month, I think it's not easy to remove the lens from the bag.
Yes.
And the chances of zonal dialysis are very high. and damage. And when you are putting a multifocal lens, exchanging it with a multifocal lens, then it becomes very, very dangerous. And that is what my message is personally. And someone has asked which piggyback lens, and piggyback lenses are from the IOL company REENA, the original. And IOCare has also come out with a 4-plate lens. And the good part is in these lenses, their anterior surface is convex and the posterior surface is concave. So it fits, there is a space between the two lenses. It doesn't touch each other. And that is the reason why there is a little chance of haze at the interface. And they work well, and their predictability is also good. The power predictability is also dependable or reliable.
One can put an ICL also as a piggyback.
ICL, but it is expensive.
Yeah,
It is expensive.
It is expensive.
So I could also add one thing that as Dr. Sethi very nicely showed the video, that cutting the IOL completely into two halves
is not necessary
all the time. So even if we cut half of the optics, then we can nudge it through the by taking it out, and that actually the wound edge can act as a fulcrum for the IOL to come out. So that way, cutting whole of the IOL into half is not required all the time.
Not at all.
So cutting only partial or half of the optics is enough most of the time. So we can take it out, especially in foldables, so it is not a problem.
I will say that counter support by Sinskey hook of the optic at the other end. So that avoid the slippage of the lens. So if we counter the force, counteractive force is applied by the help of a Sinskey hook. Secondly, I will not go up to the midline, up to the center, but I will slightly go beyond that, because we are otherwise then we require 3 millimeter incision. Our wound has to be enlarged. If we go beyond it, so we can easily remove it from a 2.8 millimeter incision. And 2.4 millimeter is not wise.
So if it is a hydrophilic lens that comes out even with half of the optic cut, but it is hydrophobic, then yes,
true.
Beyond a little bit more than half is required.
So many techniques are described. Whatever we are describing, that is a Techman's technique. You just remove a quadrant of the optic, and rest of the IOL you can rotate it out of the.
But placing an IOL scaffold is one important message which is conveyed, and this is one more place of using an IOL scaffold.
That is what a comment I was going to make. Even while taking out the first lens, once he broke the haptic, she should have put a replacement lens first before taking it out.
Yeah, that is a very nice scaffold thing. Is very nice.
Very nice surgery.
Thank you.